Thank you for joining SHM for our Education Consult series. Today we'll be looking at challenging patient communication. I'm being joined by Dr. Lily Ackermann and Dr. Lora Sowunmi, and I'm Dr. Christiana Renner. Today we are going to define common communication conflicts and discuss approaches and tools for challenging conversations. We'll then analyze factors and ethical considerations that lead to cultural conflicts between physicians and patients, and finally explore techniques for cultural conflict resolution in the healthcare setting. Dr. Ackermann, thank you for joining me today. I'm a newer attending, and I've noticed that I've had a lot of challenging situations with patient communication. I just don't feel prepared. Can you give me a little background on this?
Sure. Communication skills are unfortunately not often part of a formal curriculum in training. Emphasis is mainly on clinical skills, less on communication, and the expectation is that communication skills can just be learned by observing. Cultural diversity in hospitals and clinic are also increasing. We do need tools to understand these differences. We need lots of practice to improve, and if communication skills are not addressed, it can lead to patient harm and increased burnout. There are three factors that lead to communication breakdown. The first is situational. Location in a crowded area, for example, a noisy space where there's poor staff interactions, language barriers, time constraints, and having to deliver bad news are some other common scenarios that lead to a poor situation. In physicians, there can be personal biases, lack of knowledge, sleep deprivation, uncertainty, individual burnout, and poor communication skills that can also lead to a lack of empathy. And in the patient, know that patients aren't difficult just to be difficult, but in terms of attitude, patients can be angry, abusive, non-adherent. They can have medical conditions such as substance use, addiction, uncontrolled pain, and personality disorders. The Kalamazoo Consensus Statement is from the literature and identified 7 essential communication tasks. The fundamental task is to build the patient-doctor relationship. Start by opening the discussion, gather information, understand the patient's perspectives, share information that you have in patient-centered and patient-friendly language they can understand. Reach an agreement about problems and plans, and also provide closure at the end. There can be some consequences of poor communication. Patients can be labeled as a difficult patient in the chart and in charts going forward. Healthcare disparities can worsen. There can be diagnostic errors, fragmented care, and increased morbidity and mortality. Among physicians, decreased diagnostic accuracy, premature closure, they can have decreased empathy, they can deviate from standards of care, and this can lead to moral injury and distress.
Wow, this is really resonating with me right now.
Here's some common scenarios to discuss in terms of healthcare communication. One is requests for unnecessary tests or medications, such as antibiotics for viral infections or repeated radiology studies, verbal or physical abuse, unrealistic expectations. It's important to explore concerns, develop a mutually agreeable goal, frame conversations and plans in terms of what can be done, discuss reasons for not honoring requests, avoid inappropriate care. There can be non-adherence to treatment, hostile patient or family members, bad news or outcomes, uncertainty. It's important to be honest and accurate about the patient's condition, not to speculate, discuss uncertainty at present and future uncertainty, and set expectations. Secure buy-in for the realistic next steps, and empathize with the toll of uncertainty. And the last one that we're going to focus on in this segment is exploring cultural differences.
Yeah, that's really something that I'm struggling with. In fact, there's a specific case that I'm wondering if you or Dr. Sowunmi can help me with today. I had a really difficult patient interaction. I confess I am feeling a little burnt out. Dr. Sowunmi, can you help me?
Oh, yes, I can help. Sorry, I'm so sorry to hear about what's going on. Can you give me more information about the situation?
Well, this morning I'm doing admissions and I picked up a 72-year-old widow who was admitted with 6 months of abdominal pain. She recently came here from Bangladesh. She doesn't speak much English, and her son brought her in, and he didn't want me to use an interpreter. This was really hard for me because he seemed to speak for her and not let her answer the questions. I couldn't tell what he was actually translating. But this is really important because she had a CT scan done in the ED and no one had discussed the results with her yet. The CT showed peritoneal carcinomatosis and advanced colon cancer. And her son told me he wasn't going to tell her about this because of their cultural background. He felt she would not be able to tolerate hearing such a devastating diagnosis because her brother died of colon cancer, even though he had undergone treatment. Can you help me?
Yeah, that sounds like a cultural and ethical dilemma, and I definitely have information on dealing with this.
Wow. Yeah. Please tell me about it.
Yeah, so first I'll give you some background. There are many sources of cultural conflict. Some factors are the minority, ethnocultural background, language barrier, conflicts with relatives regarding critical medical decision making, communication of bad news, and practical aspects of care. There are also differing definitions of what constitutes good care. The family's view focuses on a more holistic, life/well-oriented approach, whereas that of healthcare professionals emphasizes the biomedical care model. There might be incongruent beliefs about the causes and treatment for an illness, religious beliefs, cultural norms, and values. And discrimination also plays a role in this. Studies have shown that experiences of discrimination and expressions of ethnic identity are positively correlated. Internalized roles are important because patients are dependent on other family members who act as translators or assistants during daily life because of a lack of knowledge of the language or culture. As far as the ethical considerations, there are a few to discuss. Health inequity is exacerbated by communication difficulties when cultural and language barriers are present. When families request physicians lie or not disclose to patients their diagnosis, prognosis, or treatment options, physicians must balance respect for cultural and social norms with ethical principles such as truth telling. Truth telling is important. It's a foundation of the bioethical principles of autonomy, beneficence, and justice. So physicians need to understand that patients with medical decision-making capacity have a right to not know or to delegate truth telling to a surrogate. Furthermore, relying on family members to serve as interpreters is problematic. Family members are not familiar with medical terminology. There can be interpretation, inappropriate editing or polishing of information, difficulty discussing sensitive or embarrassing clinical information, and also patient's autonomy could be affected as the patient's voice may be silenced. Finally, family members being interpreters distracts from their ability to provide emotional support to their loved ones and increases their burden during an already stressful healthcare encounter.
These are some tools to help repair a relationship with an upset patient. It's the heart mnemonic. First thing to do is to stop what you're doing, give your patient undivided attention, take a few breaths, and be aware of some nonverbal cues such as stance and tone. H is for hear. Actively listen. Let the patient talk without interruption and reflect back and summarize what you heard. E is for empathize. Use nonverbal language such as eye contact, nodding, smiling when appropriate. Within this, use the save mnemonic from some verbal tips. S is for support, saying I'm here for you. A is for acknowledge, saying something like you have a lot on your plate. B is for validate, saying something like I would feel this way too. E is for emotion naming, you seem upset. And then going back to the heart mnemonic, A is for apologize. Saying sorry that the expectation wasn't met is not an admission of guilt. R is for respond. Respond by addressing what you can do realistically, set expectations and time frame, and thank them for sharing them with you. Dr. Sowunmi, how do you apply this in the cultural setting?
Wow,
Yes,
wow, this is really helpful. I wonder how I can, I think I need to have lunch and then go back down. Dr. Sowunmi, can you help me apply this to this specific situation?
yeah. So we can talk more about conflict resolution when cultural conflict is involved. Some similar tools here. You want to demonstrate empathy, encourage active listening. This involves not only hearing the words that are spoken, but also understanding the cultural context and nonverbal cues, and to be compassionate. You want to strive for cultural competency, viewing it as the ongoing process in which the healthcare professional continuously strives to achieve the ability and availability to work effectively within the cultural context of the patient. You also want to conduct a cultural assessment in which you gather the major areas of worldview and social structure factors for the patient, including their cultural values, religious, philosophical, or spiritual beliefs, economic factors, and educational beliefs. And then you want to incorporate selected aspects of the patient's culture into the patient-centered care plan. Seeking intercultural learning is important. The patient's actions should only be evaluated after knowing the reasons for their behavior. You want to appreciate cultural diversity, listen to and observe people, and project the feeling that the other culture is respected. And that will make it easier for patients and their families to feel safe in the healthcare network. And lastly, conduct cultural awareness training, which is more hospital-wide. And this includes education on different cultural norms, values, and communication styles. Now, as it relates to this specific scenario, when a family is requesting to hide the diagnosis, don't overreact. Listen and try to understand the rationale for the request. Acknowledge the request. For instance, you can say, I appreciate you wanting to shield your mother from harm. Empathize, that goes a long way. You can state, for instance, I want to do everything possible for your mother's well being. Relate to the family. You can also let them know that truthfulness is vital to you as a physician and also as a human being. And then there's other suggestions that you can also offer. Promote an atmosphere of open dialogue, use medical interpreters and other support staff like social work, and chaplaincy and patient representatives to fully support the patient and their families, and try to understand the level of involvement the patient wants to have in their care. And remember that when you're gathering this information, the diagnosis does not need to be disclosed.
Thank you for this is really, really helpful. And I think I can take a lot of these things and apply them. Do you think it would be okay for me to talk to one of the nurse managers who's from Bangladesh to help me understand the cultural milieu of this patient? Is that allowable?
Yeah, I think you can definitely, within HIPAA constraints, discuss this and try to get more information on the cultural background. That would absolutely be okay to do.
Okay.
So in summary, this is a tough situation. You want to recognize that. You want to create the right mindset. Be attentive to what is said and what is unspoken. You want to use your skills of active listening, effective communication, and empathy comes up again. You want to collaborate rather than oppose the patient and let them know you're on the same team. You want to take advantage of some of the tools Dr. Ackermann mentioned earlier, like the heart and the save tool, and de-escalate if the situation is getting out of hand, and make sure you establish healthy boundaries.
Okay, well, thank you so much for sharing your wisdom with me. This will help me as I work with this patient and also teach my residents moving forward. I think these are some of the references that we have for this, and we thank you for joining us for this discussion of challenging patient communication.